and then I will start the webinar properly, and then I will get you hosting, and you should be fine. Good luck.
Cool. Let me know when we have to go ahead to just begin.
Okay, starting now. We will leave it for a few minutes to just let some people join, maybe 5. But otherwise, we are ready to start, and I'm super excited.
So people can see us now, right? Yeah.
Now.
Yes. Okay, cool. Got it. We'll just be starting in 5.
Arush?
For those who have just joined, we will be starting in 5. Okay, good evening, ladies and gentlemen, and welcome to one of the Witch Student Surgical Society's most anticipated and enthralling events, the Great Debate. I am Sudarshan Pillai and have the pleasure, alongside Priyanka Amrithal, of being tonight's host. And besides COVID-19, with the current borderline hypothermic conditions and weather, I'm glad we can do this from the comfort of our own homes and offices. And I trust, with the chemistry and fire that has been felt with even the vestiges of previous events, this event will deliver some much needed heat into our lives. This is an evening where some of the most accomplished and erudite and adventured surgeons have their surgical and medical prowess on display. Out of all the recent years, I do think this year we have an extremely varied group of surgeons, from those concerned with cosmetics and the beauty of plastic surgery to vast reaches of cerebellum with neurosurgery. The lineup is bound to get us thinking, requiring our lights to be switched on upstairs at all time. And on that note, in the likely event that ESCOM pulls an ESCOM and we lose one of our speakers, we do have contingencies in place as a backup. I have spent the vast majority of the event hyping up today's surgeons, so I believe it is only fair they receive an introduction of equal razzmatazz. And so I would like to hand over to Priyanka, who will be giving us an introduction of our potential master debaters.
Good evening, everyone. I am Priyanka Amrithal, and as mentioned, I will be your second lovely host for tonight. Before we get into the nitty-gritty of the event, allow me to introduce our respected MVPs of the night. I truly believe the likes of countless celebrities and models would agree with all the transformations and metamorphoses they undergo. Plastic surgery is truly a mesmerizing art. Tonight, we have our very own Da Vinci in Dr. Davy Chen. In the theater, he's an artist. Outside, an amateur chef, student of life, scientist, art historian, gastronomist, and film critic. A doctor of many talents and one who always aims to uplift others. The magic that stems from plastic surgery would be indiscernible if we were not able to see. After all, beauty is in the eye of the beholder. Our second speaker will be Dr. Laithwaite, an ophthalmologist specializing in the diagnosis and treatment of ocular disease. From treating cataracts to uveitis, Dr. Laithwaite is fulfilled in providing her patients the ability to see and hence a greater quality of life. Our third speaker is a lover of travel. Whenever he's not being occupied by matters of the human mind and brain, he adores spending time with his family. He is none other than Dr. Diapo Gerald Mohale, a neurosurgery registrar at our very own Wits University.
And then we have another one of our own, Dr. Sunil Satyapal, a Wits graduate and specialist in orthopedic surgery. Having done his internship in urology, general surgery, and orthopedics, as well as having worked in the UK, he has a wide range of expertise and experience. In the UK, he was a senior house officer while working in Royal London Whitechapel. This area was essentially known for the killings that took place decades ago due to Jack the Ripper. So it's clear that Whitechapel is not foreign to men that are good with sharp instruments, and Dr. Sunil Satyapal is no different. This was where Dr. Satyapal's love for orthopedics came true. And after working through countless fractures and trauma in areas once subject to Jack the Ripper, it seems like Dr. Satyapal was not the only person to be prolific with sharp instruments. For Dr. Satyapal, the specialty is not simply navigating the second hardest tissue in the body, but also the joys that come with enabling people's motility and normal standards of living. Last but not least, our fifth speaker, Dr. Salim Chunara. He is a urologist, and he has special interests in urinary tract cancers as well as robotic surgery. For any other overly concerned medical students, don't worry, please. This type of robotic surgery is not the technology which could render us obsolete in the near future. So relax, please. A special mention should be given to Dr. Chunara for his brilliance during the pandemic. At the onset of the pandemic, Dr. Chunara and a few like-minded individuals started an NGO called the Masks for All Africa campaign, creating awareness about face mask use and distribution to underprivileged communities. Dr. Chinara is currently the chairman of this organization, and honestly, it's just brilliant. And with that, I would like to move on to the proceedings. Back to you, Priyanka.
Ladies and gentlemen, round one. So our round one will be just a slight warm-up where we're going to get to know a little bit more about each of the surgeons as well as their specialties. May their words and wit be as sharp as their scalpels. Without further ado, Dr. Chen, Dr. Laithwaite, Dr. Mohale, Dr. Satyapal, Dr. Chinara, let the battle of the brains commence. Over to you, Dr. Chen.
Good evening, everybody. How are you? I'm Dr. Chen, representing Plastics and Reconstructive Surgery at tonight's event. Thank you to Wits Surgical Society for the invitation. I know you're probably expecting me to talk about boobs and butts, but I'm not. I'm going to share my screen now. Just give me 1 second. I think you guys need to stop sharing your screen so I can start mine.
Give me 1 second.
All right. So who are we? Plastics and Reconstructive Surgery. Well, we are probably the most popular specialty in the media, probably second to trauma surgery. So what makes us so special? Well, if you think about it, we are the only true general surgeons of modern day medicine. Although general surgery have identified themselves as such, the field is restricted to the abdomen. We, on the other hand, literally span from head to toe, from hair implants to foot reconstructions and everything in between. Then plastic surgery principles can be applied to life principles. I'll talk more about that later. Sorry, just give me a second. My slides are just jumping. So without us, all the pods will have hardware exposure. Ophthalmologists will constantly be prescribing eye drops for lack of ophthalmos. Neurosurgeons won't bother with spinal bifida surgery. And let's be honest, urologists consult us on whether their Fournier's gangrene post-debridement is ready for a skin graft. People might not believe you, but we do save lives. Although most of our surgeries are never dire emergencies, we improve the quality of life of patients and therefore give them a reason to live. Lastly, I will show you case scenarios as to why magic does exist in medicine. So I loosely classify our work into reconstruction, rejuvenation. Sorry, excuse the dogs barking in the background. So I loosely classify our work to reconstruction, rejuvenation, and cosmetics. Reconstruction is restoring things back to the normal anatomy. I think an example which epitomizes this is the case of hand replantation. We restore bony stability, arterial inflow, venous outflow, nerve continuity, muscle and tendon alignment. So time is the enemy of youth, and unfortunately, gravity can take its toll on skin elasticity. Some people call it breast reduction. I prefer breast rejuvenation. Sorry. We are not only making them smaller, we're also reshaping them. And this is just an example of our infamous skin marking that's seen on social media filters. Cosmetics is all about achieving the ideal and aesthetically pleasing shapes, which we either appreciate looking at or enjoy having. A patient with gynecomastia may want a manly chest, whereas a lady may want to accentuate her womanly contours. So what are the perks of being me? Well, firstly, we have minimal emergencies, which means that we can call from home most of the time. And also, I don't know why my slides are jumping. Sorry, just give me a second. But yeah, so we are also essentially sculptors working with the human body as our medium. And like I said in the beginning, we have to be able to work with bones, fat, muscle, skin, and nerves. So we are jack of all trades. Also, we work with a lot of our other surgical colleagues, therefore making good friends and plenty of banter in between. We improve the quality of life of our patients. And most importantly, we love our job. If I had to think really hard about the downsides, well, I guess we don't go home being covered in plaster of Paris. And we don't smell like urine at the end of our workday. Yes, people say it's not brain surgery, but at the end of the day, everybody wants to be your friend to have a quick consult about either their own or their partner's problems. So just a quick run through of the things that I get up to. This is me pretending to be an orthopod, and this is work as an ophthalmologist, and this is a neurosurgeon. And this is a bit of the magic I was talking about, using geometry to correct the tissue defect after excising a skin cancer. This is a paramedian forehead flap to do an alar reconstruction for the nose. And this is me living my own life. This is me getting to work with celebrities. And this is me having time with my family, even though I'm a registrar. And this is me on call, chilling with my son and my dog. Thank you.
Thank you, Dr. Chen. We would now like to hand over to our ophthalmologist, that is Dr. Laithwaite.
Right. Good evening, everyone. I'm Jenny Laithwaite, and I'm an ophthalmologist. If I had all my career choices to make again, I suspect that you would find me exactly where I am now, enjoying the field that I have chosen. One of the things that I love about ophthalmology is the variety of patients I see. Considering I'm just an eye doctor, I have the opportunity to assess and diagnose patients with neurological conditions that present with ocular signs. I'm involved with patients who have fractures from trauma. I have patients who need help in getting bodily fluids to drain in the right direction, just not that close to the eye. I'm able to perform procedures to mold and reshape the tissues around the eye, and I see patients of all ages. I even get to play with children sometimes, so it can be a lot of fun where I work. Now, what is it like to be an ophthalmologist? Well, your idea of theatre that you may have from other specialties has to change. The ophthalmology theatre is a very civilized place. No more late nights dangling on the end of an abdominal retractor, hunting for swabs, lost under loops of bowel, desperately clinging to the edge of the theatre table with not an inkling of what might actually be happening in the surgical field. We sit down to operate. We maintain an almost bloodless field and use instruments like those used by a jeweler instead of the carpentry power tools used in other specialties. No one can deny the beauty of the eye seen up close. Forget auscultation, palpation, percussion, lamentation, fermentation, whatever other techniques they teach you in medical school these days. In ophthalmology, we can see the problem. And I love the intricate beauty of the structures we see as we assess each part of the eye. Ophthalmology is a rapidly advancing technical field. I have a pretty basic practice setup, but I counted about 10 electronic devices that I make use of regularly to better assess my patient's eyes. We all know that the kid with the best toys wins, and we have some of the coolest toys around. So now on to something a bit more serious. The primary aim of ophthalmologists is to eliminate causes of preventable blindness. Cataracts and inadequate spectacle correction are the biggest contributors to this worldwide. In South Africa, there is an estimated 250,000 person backlog in surgery. This is 250,000 people who are blind or severely visually impaired due to cataracts. Apart from the obvious visual problems with having cataracts, poor vision is associated with other problems. In 2018, a study demonstrated a 50% reduction in the rate of cognitive decline in elderly patients who underwent cataract surgery compared to those who did not. This may be explained by their increased physical activity, richer social networks, better mood, and higher self-efficacy. So let's take a whistle-stop history tour of cataract surgery. So cataract surgery has seen an exponential development in technique and complementary technology over the past few decades. A cataract, or doggerect in this case, is a misty opacity of the ocular lens, which prevents the transmission of light through the eye to the retina. More than 2,000 years BC, there are descriptions of patients undergoing couching. In this procedure, a needle is inserted into the eye to push the cataractus lens backwards. This clears the visual axis for light to pass through the eye to the retina. As long as the patient didn't lose the eye to infection, it could be pretty successful. In the mid-1800s, Albrecht van Graaf developed a knife which he used in a cataract surgery technique. The knife was inserted across the eye from 3 to 9 o'clock on the cornea, and a 180-degree flap opened. The entire cataract was then removed from the eye. Both of these procedures resulted in an eye with no lens. This meant that patients needed to use thick Coke bottle spectacles to bring images into focus, which didn't give a great visual outcome. Around 1950, the cataract extraction technique was refined to remove the cataract, but leaving part of the lens capsule behind. This enabled the insertion of an intraocular lens into the eye in the position where the cataract had been, so that a far better visual outcome could be achieved. The 1980s saw the development of the phaco ultrasound probe. This probe breaks the cataract up inside the eye, allowing the surgeon to work through a much smaller incision, which causes less distortion of the cornea. Along with this came the development of foldable lenses, which are slipped into the eye through the tiny incision and then unfold into the lens bag to give an excellent visual result. The end result of these advances in cataract surgery is an operation performed more commonly and more successfully than any other, and one that restores function and quality of life to the patient, if we can get it to enough people. This young lady is a patient I performed cataract surgery on as part of an outreach project in Venda. She's diabetic and also deaf. She had dense bilateral cataracts. Performing surgery for her has enabled her to function in her community and take care of herself again. This is what I love about my field.
Brilliant. Thank you very much, Dr. Laithwaite. I would now like to hand over to our neurosurgeon, that is Dr. Mohale. Over to you, Doc.
If you can just give me a moment. Good evening, everybody. Please indicate to me if you can see my screen.
Not yet, Doctor.
Can I be assisted in that regard? I'm unable to actually.
Hi, Doctor. I'm going to see if I can open it on my side and share it from where I am currently. Give me 1 moment to see if I can get it open. It is opening now. I'm going to.
Can I share it? I think I'm able to share now.
Yes, you have managed. If you can just present, that should be fine. Wonderful.
Of course. Okay, apologies about that. Neurosurgeons are probably the smartest people, yet not technologically smart, it seems. So basically, what is neurosurgery? I mean, they are the physicians that specialize in diagnosis and surgical management of disorders of the nervous system. Basically, these are the central processing unit. It's the central processing unit of the whole body. Types of surgeries that we do. So we do emergency and elective surgery. You're usually on the run as a neurosurgeon. Time is of the essence. So each organ has its own time, and the shortest probably time spent without perfusion for any other organ cannot beat that of the brain or the central nervous system. For elective cases, usually you might be a bit relaxed, but you still have time that you need to consider. Mostly, you definitely have to sort of speedily attend to your patient as quickly as possible. Now, the next slide is not for the timid, just as neurosurgery is not. So in the emergency, mostly what we see is head traumas. Other than that, we also attend to spinal traumas. The injuries are usually gruesome, so you need to have a liver for what we do, and you have to love it. More emergencies like infections, but not as smelly as the general surgeons or the urologist type of infections. And other emergencies include vascular lesions and might be issues of obstructed cerebrospinal fluid. For elective cases, so basically the tumors, and also you still have the vascular surgery that you do, and the functional neurosurgery, which is the creme de la creme of neurosurgery, if one is to put it. For other elective cases with tumors, could be tumors of the spine as well, and you also do some orthopedic part. As you can see, we also have our instrumentations that we do, nice, colorful, and usually they are done with greatest precision. For vascular lesions, also on the spine, we also attend to them. And these are the trickiest surgical procedures, as many millimeters away from very intricate and very fragile spine, and with very harsh consequences that will have you avoiding your patient for a lifetime. So you need to be on point. For elective spine cases, we do degenerative spine disease. That's where we get to do a bit of orthopedic work. And we also do corrective surgery. That's where we try to pretend to be plastic surgeons. The subspecialties in neurosurgery, one can choose neuro-oncology, pediatric neurosurgery, neurotrauma, intensive care unit, spine and neurovascular surgery. Base of skull is for those who are brave. Recent advancement in neurosurgery, we have endoscopic brain surgery. It's been in the literature for some time, but now it's more gaining popularity. We also have stereotactic adjuncts to what we do, meaning basically this is like your TomTom or navigation system into your brain to avoid injuring the healthy part of the brain or to getting minimal for minimal neurosurgical procedures. Further recent advancement, we do also keyhole, which is basically, as it says, through a keyhole to try and get into the brain and operate microscopically lesions that might be bigger than the eye without damaging much of the brain. Awake neurosurgery is also gaining traction. It's more popular now. See it in the media these days, where we operate in patients speaking or playing instruments or singing. For future advancements, robotic surgery is now under great attention and research for one to be able to operate while in Cape Town for a patient that is in Cairo. Further future advancement, there are connectomics. Basically, this is just to differentiate the brain oscillations, different parts of the brain and what they do, and individualize it to every specific, to every patient, which this will lead to one being able to preserve function of the patients with any lesions that requires to be operated. Now, the brain, what a beautiful organ. So this is the center for the CPU for all parts of the body. Nobody can do without. It is an eloquent organ. It is peculiar in its form. It's delicate in character. It's got complex functions. You will probably complete medical school without understanding 0.5 of it. And when you get into neurosurgery, you enjoy it, you love it, you fall in love with it, and it is the love that makes you understand it rather than the study. Why did I do neurosurgery? It is unlike any other discipline, little to no room for error. Micrometers from disaster. Damage is irreversible. It is without doubt in its own league, second to none. Maybe rocket science, so some say, but really, is it? Suitable candidates for this, for neurosurgery, best be that those who are well-rounded. They must have a bit of OCD, some DSM criteria there, but they should be calm, collected while under pressure. For pressure, there is in neurosurgery, and most of the time is you and the patient. And one needs to employ a bit of calmness and sanity to bring out the best outcome for patient. You need to be an efficient somebody, meticulous, systematic with your approach in problem solving, passionate and focused, and has greatest precision, high intellectual curiosity. Don't get me wrong, I'm not saying you should be intelligent, but you should just have a high intellectual curiosity. Neurosurgery is ever changing. If you're not curious, you will not know. You will remain behind. You must have a very good hand-to-eye coordination. Stealth is very important, as every single millimeter matters in neurosurgery. You need to be patient, and you need to be compassionate and have endurance. You're mostly dealing with patients and their families. And most of the time, it is a lifetime of one patient with his family. A long journey might seem tedious if you don't have patience, but all in all, the slow progressions that you get from these patients and the quick ones that you celebrate immediately are comparable to none. For you know, no one else could have done what you've done. Well, what do you need? First, to become a neurosurgeon, you need to complete your MBCHP, do your internship, community service, walk the path like everybody, and write your general surgery. But you then need to write neuroanatomy primaries on top of your general surgery primaries. Not very difficult, very basic, but other than that, it is still neurosurgery. stage 1 for you, to which, if anybody understands from medical school, very little neurosurgery is being taught or is being enlightened to the students. You need to be in your medical officer years. You need to do some time in neurosurgery, whether it is where you go on your spare time or you actually lucky enough to rotate, or rather to get a post there. It's of great advantage. So you get the exposure, as it is known that the exposure is not enough undergrad. As a neurosurgical registrar, one has to do the college exams, which are starting with the primaries. If you do not do them while you're still as a ComServe or as a medical officer, you need to push for intermediate, and you need to complete your logbooks and eventually do your finals, and you start doing big people's things. Thank you very much. Yeah, so they say. We don't say it, they say it. Thank you.
Thank you very much, Dr. Mohale. Personally, I've always said no to brain surgery, but right now I'm considering changing my mind. Let's see if our orthopedic surgeon can change it back. And with that, over to you, our orthopedic surgeon, Dr. Satyapal.
Hi, guys. Hello.
Hi, doctor.
Can you hear me?
Yes.
But I can't see my video.
Are you unable to see your screen?
Yes, I'm unable to see my screen. Yes, I can now. Okay, so I can't screen share because I'm working off my telephone because of load shedding. So Sudarshan, you would need
Fantastic,
to put
yes. No problem. I'm getting to that now.
Okay, while we're waiting, basically orthopedics is, I think, the coolest toys that we have. Things like a drill. Everyone wants one of these. That's why we love shopping at Builders. A hammer. My spanners. So yeah, while Sudarshan is setting that up, I can start a bit. So to become an expert, everyone has to start at the beginning. Except for golf, we're still at the beginning. Are the slides just going to run, Sudash?
Yes. Just tell me when you need me to change it. Can you see it now?
Yes, I can.
Okay, perfect. Just let me know when you want me to change it and I'll change slides.
Okay, great. Next slide.
Hi, Dr. Satyapal, are you still there?
Next, Sudash. There we go. Okay, so am I back, Sudash?
Yes, you're back.
Oh, great. Orthopedic surgeon always come late to the party. So basically, orthopedics is a condition involving musculoskeletal system, which includes your bones, joints, ligaments, tendons, and muscle. And we are important to basically get people to do activities, and we restore mobility and we keep our nation moving. And that is why we have to keep on walking. Next slide. Next slide, Siddharth. Hello.
Give me 1 second. Just need a. There we go.
No, we're right at the end. There we go. Next one. Okay. We all know someone who has been stopped and unable to function due to pain. And this can affect people of any ages, a child with scoliosis, a person sustaining traumatic injuries requiring limb-saving procedures, or an elderly grandparent needing a joint replacement. Next slide. So patients benefit from an orthopedic surgeon consult. We want to restore function to pre-injury levels and to continue with activities of daily living. A person injuring their arm has to go back to work. A person playing rugby or cycling has to return back to their sport. And what is most important is getting a person to look after themselves, be it walking to the toilet, bathing, changing themselves. But everyone thinks that orthopedic surgery is just surgery. We do non-surgical options as well, from rehabilitation, orthosis, and analgesia. And surgery is the last option. Next slide. Sudash. As an orthopedic surgeon, you are trained initially as a generalist, and that means you can treat any joint in the body, even spine. So neurosurgeons, beware, we can take away some of your job. But then you can choose to become a super specialist in an area, be it hip and knee to do arthroplasty, foot and ankle, upper limb surgery, including shoulder and elbow, spine surgery to correct scoliosis, degenerative spine, basically spinal stenosis. And then there's sports medicine. South Africa is a sporting nation, from rugby to cycling, tennis. Our cricket team is doing not so bad now, but yes, we can probably get them back up to scratch. Next slide. So initially I was going to do BCom. I probably would have been a partner at PwC playing golf 4 days a week, but then Wits won the battle. Best decision I made. Was a big adjustment living away from home. And second year was the greatest. Prof. Tobias was our anatomy prof. He wrote the book, Man's Anatomy. And that is where my passion for the surgical field started. Next slide. Sixth year, we were known as junior interns. We got paid 200 Rand per month, which wasn't too bad back in the day. And then internship, I did 4-month blocks in King Edward, Durban. It was an excellent teaching hospital. I started off with obstetrics and gynae. I knew after that 4 months that it definitely was not for me. Then I did general surgery, and within that general surgery block, I did orthopedics and urology. So it was either being a carpenter or a plumber. My last block was medicine. The stethoscope was a bit too heavy for me to carry around, so I decided to probably not pursue medicine. Next slide. Post-internship, one never knows what to do. So I went initially to become a resident medical officer at various private hospitals in the UK. And while they decided to try accident and emergency as a senior house officer, Ipswich. In the UK, they used to love South African doctors. Reason, we worked hard, well experienced, and there was never a crowd when you worked in the accident and emergency. Patients never worked more than, waited more than 2 hours. Thereafter, I did orthopedics at Royal London, Whitechapel. As Sudarshan said, home of Jack the Ripper. But those were none of the patients that I saw. Next slide. So I had to come back home, didn't want to specialize in the UK. Reason being is home is where the heart is. I trained as a registrar in orthopedics at the UKZN program. You go through your general orthopedics rotation, then you go to the specialty, arthroplasty, pediatric orthopedics, and spinal rotations. Our profs are basically well published in journals throughout the world, as well as textbooks. While a registrar, you present at congresses, be it your local registrar congresses, as well as the South African Orthopedic Association Congress. Thereafter, I did my higher diploma in orthopedics. Wasn't important to do that, but it does sort of give you a grounding to write your fellowship in the program. And when I specialized, we didn't have to do the MEd, so now registrars have to complete and get their fellowship doing an MEd. Next slide. Sudash. After getting my fellowship, I worked at a local hospital, RK Khan Hospital, mostly trauma, did some elective work, but lots of trauma. In Nkosi Albert Luthuli, excellent hospital, looks like your private hospitals, where I did arthroplasty for 3 years. And then I joined one of the largest practices, orthopedic practices in Durban, maybe in South Africa. We are 11 partners. And I practice out of Umhlanga doing arthroplasty, but also I enjoy trauma. Next slide. Next slide, Sudash. So, you know, everyone picks on orthopedic surgeon that strong as an ox and half the IQ. But a study done in 2011 at Oxford showed that as between orthopedic surgeons and anesthetic registrars, both male, there were no female orthopedic surgeons at that time. We won the group strength, as well as the intellect was quite a few points higher than the anesthetic guy. So strong as an ox and twice as intelligent. Next slide. So it was carpenter. As you can see, the coolest tools, we dress well, and we always look sharp on the job. Next slide. Sudash?
I think that's it.
No.
The
next talk with my cases.
The cases will be in the next round. Thank you so
Okay.
much for now, Doctor.
Thank you very much for that, Dr. Satipal, despite your difficulties at home. I would now like to hand over to our final panelist and specialist urologist, that is Dr. Salim Chinara. Over to you, Doc.
Good evening. Thank you very much. Just sharing my slides with you guys. I must say, I really appreciate and very humble by this request to participate in this really prestigious gathering, and just to let you know that you're in good hands. So my motivation for doing urology, for becoming a doctor, really was my late mom, who succumbed to bladder cancer, and she had a urologist as her treating doctor. So I pretty much see my time in urology, or my decision to do urology, as a destiny, which I'm very, very pleased about. So yeah, so urology, you know, it's an interesting specialty. You know, it deals with the congenital and acquired disorders of the urinary tract. So we're dealing with the kidneys, the ureters, the bladders, and the interesting thing here is about the anatomical balance that is there, that is present in the urological anatomical system. You know, 2 kidneys, ureters, bladder. The bladder being central to this whole very dynamic anatomical system, with even the testicles somehow linked up to the central component here, which is the bladder. So very interesting. And you know, just for good measure, God Almighty left the foreskin also intact to allow the urologist to put the final touches to the organ of procreation. So we are obviously indeed very, very chosen in that regard. Urology, yeah, it's interesting how sometimes, you get a patient coming to see you and accidentally they meant to see the neurologist, not the urologist. But you say it really quickly, it kind of does sound like you want to see the same specialty, the same specialist. What do we have in common? Interesting. I mean, the only thing you don't think we have in common really is the anatomical demarcation of the head. So I guess the head which houses the brain, which is the seat of all emotions, and the head of the penis, which houses the glands, which is the seat of the best emotion, I would say. So yeah, in the past, I mean, we would say to patients, how are you urinating? Is any trouble urinating? Times have changed. We got to ask people, are you having any trouble streaming? I mean, that's just the way the world is going now. Talk about kidney stones. I mean, it's almost like as if people are just waiting for them to be converted to diamonds and obviously not wanting them to be removed. And obviously, the ever worrying concern of most males coming to the urologist, dreading the digital rectal examination. So choose your specialist very, very wisely in that regard. So urology, yeah. So I mean, urology is about power, right? I mean, because we deal with organs that are like factories. I mean, they're constantly producing substances that are integral to life. So if we think about the excretion and secretions, in this case, semen and obviously urine. Ophthalmologists, what do they have? I guess they have tears, right? But kind of depressing if you have your patients crying all the time. The orthopods don't have much secretion, they're kind of dry as a bone. And the plastic surgeons, well, those septic, pussy, smelly wounds, not so cool, I guess. So, I mean, the kidney, quite an amazing organ, integral to human life, filters your entire circulation, producing as an end product the urine. One can just look at even men trying to mimic the functions of the kidney came up with the machine that's huge compared to the actual size of the kidney. So quite a remarkable organ. We speak about porphyria. I mean, we've all experienced this, right? The sense of release as the bladder pressure diminishes is as a result of the stimulation of nerve endings in the urinary system. An amazing feeling of satiety, I would say. Just ask those patients that present with urinary retention. It's amazing how once you relieve their obstruction, it's almost like orgasmic. They don't speak for a few seconds. So, we out there. Euphoria, well, obviously the process of ejaculation containing sperm and microscopic elements that contain the most complex genetic code known to man. Interesting how all specialists really look to the urologist to make sure that the organ of procreation and the organ of recreation is in good functioning order. Erectile dysfunction in the emergency department. This is now borne out with studies that the understanding of erectile dysfunction being a precursor of cardiac disease. Social norms, current trends, especially in younger people. We've seen this kind of thing feature in many young couples as well. Social media having a role to play, peer pressures, and obviously the mental health issues that come with that, which speaks to one of the themes related to this discussion tonight. So I'm glad we got that taboo out of the way. Urology, amazing. And one of the things that attracted me to urology was the way it moved with the times. There's a lot of technology being applied to urology to the extent that majority of our procedures are now considered minimally invasive. There are times that you don't even feel like a surgeon because you're not really handling the scalpel. Most of the procedures are endoscopic, laparoscopic, and even obviously using the robot now, which I'll demonstrate to you in a short while. So this slide speaks to one of the advancements in management of prostate cancer, so-called brachytherapy, which has led to excellent oncological outcomes, being a day procedure with absolutely not one incision made on the patient, with unbelievable oncological outcomes and cure rates probably over 95% as far as localized prostate cancer goes. Developments in the Da Vinci robotic system, which is the greatest application in robotic radical prostatectomies, again with excellent outcomes and significant reduction in both incontinence as well as impotence. And this has really changed the way we deal with pelvic surgery in the 21st century. I just wanted to just sort of give you an indication what it looks like.
Radical surgery for localized prostate cancer.
It's unbelievable. It's such fluid.
Early recognition of the benefits to the functional and oncological outcomes provided by 3D HD vision.
Obviously, skill development in laparoscopy, which is used to manage disorders of the ureters, the kidneys and the bladder is now very, very well established. I mean, if you're training in surgery nowadays and you're not trained laparoscopically, you're almost falling short of both local and international standards. And this is an interesting picture. I just wanted to show you how we can now combine both laparoscopy as well as some degree of open surgery, what we call a gel port. As you can see there, with the hand basically going through the abdominal wall and handling the kidney, has particular use in donor nephrectomies related to renal transplantation. So again, these are small, 3-4 small cuts. Patients can probably go home the day in a day's time with excellent recovery and minimal pain post-operatively. Most of the procedures that we do now, obviously for related to the urethra, bladder, the ureters, as well as the kidney. So whether it has to do with disease of the bladder, whether it's got to do with the ureter, whether it's got to do with the kidneys, we can do all these procedures via a flexible or even rigid ureteroscopy. And this is basically using the urethra as the orifice to get access to these organs, which has changed the way we deal with patients. These are all procedures that are pretty much done as a day procedure. Patients go home the same day. Demonstrated on this slide, one can see the fancy and a lot of advancement that has now been part of urology, where you get all these instruments that one can place through a fiber optic scope. Here you see a basket basically handing a stone in the ureter, which can then be extracted, by pulling out the basket. So these are amazing developments, obviously, that have taken place. Excellent technology has also been applied in most of our transurethral work. So this would include things like, you work on the prostate, which is that area where you see a resectoscope there, you place through the urethra, no incision at all on the abdominal wall. Prior to this kind of technology, patients that had large prostates required open surgery. And that open surgery required going through the abdominal wall into the bladder, removing the prostate, huge, massive, hospital stay about 3 to 4 days, and significant pain relief post-op. This has now changed with this kind of transurethral procedures for both the bladder and also tumors that are in the bladder can also be handled in very much the same way. There are also numerous disciplines that one can, take on as a career choice: infertility, female urology, which itself is a huge area. Obviously, nowadays there's a lot of work with the gynecologist, so-called urogynecology, which is now recognized as a specialty as well. Pediatric urology, which is a huge field by itself, and obviously renal transplantation, which is a very, very interesting and life-changing specialty to be involved in. So unique to surgery also is, the time you spend in theater. Physicians and guys involved in the medical side of medicine don't have this. And for me, this is really a very special time. I regard it's the time just to rest. You sort of devoid from your cell phone. You don't even have to answer the phone. Somebody else will take the call, and you're just busy, and that's your Zen time, And it's a time when you can just collate your thoughts and just get down to art, as I would think surgery is. And obviously, the other thing about being in theater is obviously all the theatrics and all the tradition that one becomes part of. Very importantly, also is your team. That's amazing. As a surgeon, you work in the theater environment with your scrub team. You have your anesthetist, who you becomes the best person in the world. You share so much of your time together, and obviously your theater staff as well. And one develops great rapport and relationship with individuals. So it's a team effort, and one I must say I enjoy that part of urology the most. So yeah, urologists can boast. Our patients are all these rich old men, right? Who all want to be young again. They're always interested in the performance levels. Who thought Botox and fillers are just for the face in plastic surgery? Urology has the fair share of requests for the use of Botox and fillers. And again, occupational hazard. No function is complete without some uncle thinking you're like a drug peddler, handing out Viagra from the boot of your car. So that's just a part of what you have to accept. And it's, like I said, urology for life. So yeah, all is left for me to say. It's like, if you don't really like urology, then all I can say is piss off. Thank you.
That was brilliant. Thank you so very much, Dr. Chinara. That does conclude our introductions on each of our respected speakers. Now we move on to round
It's 19
two.
hours.
It's important to note that each of these specialist fields takes between 13 to 14 years to complete. Being in second year, I should maybe ask why I'm here instead of studying when I have 89.3% of this journey still to go. But then again, every specialist does have, they have had their own unique experiences, both in and outside the classroom. Surgery is so wonderful, and while each deals with healthcare, all specialties are markedly varied and unique. It goes without saying that each specialty has had its own set of cases that are markedly distinguishable from others. Ladies and gentlemen, before we commence, I must remind you that a lucky draw and giveaway of a set of no scrubs will be done later this evening, but that is exclusively to a viewer who has been present throughout the duration of the event. So if you want to stay in the line for that draw, make sure that you stay tuned till the very end. With that being said, round 2 of the event, which is based on special cases, will now commence. And I would like to hand over to you, Dr. Chen, our plastic surgeon.
Thank you, guys. So let's just continue our journey. So now that I've had your curiosity, I'm about to have your attention. So Sir Harold Gillies, the founding father of modern plastic surgery, described the 10 commandments of plastic surgery. These principles may be applied to life. I'll be discussing a few of these and demonstrate their relevance. Never go into a situation without knowing what to expect and have some sort of idea of how to overcome the obstacles. This gentleman here has a central upper lip defect secondary to trauma. The problems faced include a lack of tissue, therefore tension across the wound, poor wound healing, and ultimately poor scarring. The plan for this patient was to elevate a flap along the left lateral nose, as seen by the blue line, and rotate the flap into the defect by recruiting more tissue. We have less tension across the wound. Key part of this is to minimally undermine the medial border of the wound, for it may affect the symmetry of the mouth. This is what it looks like post-rotational flap. And this is what it looks like 4 days post-surgery. Believe in your own ability. Develop your own technique and style. This one is obvious in its life applications. In the case of this chemical burn wound on the abdominal wall, the majority of surgical disciplines would choose to go for a skin graft, which will most definitely achieve the outcome of wound closure. But is it the best one? Well, in this case, after thorough debridement of the wound, it can be imagined as a rhombus, and through geometric planning of 2 transpositional flaps, wound closure can be performed without a secondary defect. Do you believe me? Well, as seen here, we have achieved wound closure, and there's no ugly mesh skin graft pattern on the wound. In life, face the immediate obstacle. Do not become overwhelmed by the problems that follow until you have solved the one in front of you. This patient had a BCC, a basal cell carcinoma excision, and local flap, which complicated with sepsis, wound breakdown, and bone exposure. What you see in the center of the photograph is the mastoid. So a skin graft will not take on bone, because if there's no periosteum, then the skin graft cannot bond to it. So what are our options? A single transposition flap of skin and fascia is designed to cover the bone, and the secondary defect of exposed muscle can be closed by a skin graft. As seen by my colorful depiction of what we are about to attempt, please note that is a pencil drain and not a cigarette behind his ear. And never be obsessed by the secondary defect, which is a resultant of your flap, until you have achieved your objective, because then you may end up designing a flap that is too small and end up putting an ugly scar on somebody's body while the flap doesn't even achieve the primary goal. As you can see here, a flap elevated is always larger than the primary defect. A skin graft on the secondary defect, in this case, the exposed muscle, can be performed. By week 2, the patient is fit for discharge. This one was very confusing when I started out in plastics. It makes it sound lazy. However, if you think about it, it makes a lot of sense. In life, sometimes the quickest route is not necessarily the best route. This patient had a malignant peripheral nerve sheath tumor on the scalp, approximately the size of his head. Post-excision, we had cranial exposure. The obvious choice would be a free flap to cover the defect, which would have achieved our objective, but in the process sacrificed the function of whatever muscle we harvest for. Instead, we scraped the skull, put a vacuum dressing on it, and waited for granulation. Once granulation was sufficient, we put a skin graft on the scalp. The results were definitely more aesthetically pleasing. The one scenario, we did a flap instead of skin graft. And the last case, we did a skin graft instead of a flap to achieve the best results. It is a further testament that plastic surgery is as much a science as it is an art form, with a hint of magic. Thanks.
That was brilliant. Thank you so much, Dr. Chen. The next speaker to present on special cases is our ophthalmologist, Dr. Laithwaite. Over to you.
Sorry, doctor. You seem to be muted.
Apologies, there we are. I just thought that I'd share a little bit about how I came to be in ophthalmology, which I didn't really share initially, and it might be helpful for you. So I was a student at Wits. I think like most medical students, I thought I was going to follow the path of whichever rotation I was doing that week. And I then went on to do my internship and my community service at Barra. During my comm service, I was very fortunate to be allocated some time at St. John Eye Hospital, and I did my primary in ophthalmology at that time. I spent a little bit of time back in medicine for a while until I did get a registrar post in ophthalmology. These days, to get a registrar post, you need to have spent time as a medical officer in ophthalmology, usually in one of the secondary level hospitals, learning to do cataract surgery before you will get a registrar post. I completed my registrar time and then was the ophthalmology consultant at Leratong Hospital on the West Strand for 5 years. And I think one of the things I enjoyed most and was most proud of in that time was the growth in the department, and specifically in the cataract surgery program, and increasing the numbers of cataract operations that we performed in restoring people's vision. In 2009, I went into private practice, and I'm now in a small independent private practice. I focus on medical retinal problems, anterior segment surgery, a little bit of uveitis, but I'm generally a general ophthalmologist. One of my passions is doing cataract surgery programs. So I participate in a program called Flying for Life, where we fly up to Venda and do cataract surgery on patients as part of a weekend project at times, and that brings me great satisfaction. But now let's get back to some of the interesting things in ophthalmology. So we talked about the pandemic of cataract surgery. Many of us have heard of Dr. Li Wenliang from the Wuhan province, where SARS-CoV-2 was first described. He was an early whistleblower, as he described patients in his hospital with features that reminded him of the 2003 SARS epidemic. Sadly, he went on to contract COVID and did not recover from it. As we all saw this pandemic start to unfold, apart from wondering what an ophthalmologist was doing in the ICU, many of us started wondering how this new disease would affect the eyes. I'm sure in other specialties you were doing equivalent assessments. So early reports confirmed that COVID causes a viral conjunctivitis. This is not something that's dangerous or particularly interesting to ophthalmologists, and not really responsive to anything other than supportive management. Then we noted all the reports of clotting abnormalities affecting the lungs, brain, and most other parts of the body. Very surprisingly, there has not really been a significant association with retinal vessel occlusions. Then all the talk about cytokine storming got the ophthalmologists worried that we might be dealing with a flood of uveitis and other immune-related eye problems. For reasons that I think I'm still unsure of, we really haven't seen these either. So in many ways, ophthalmologists have been spared being overwhelmed by ocular complications of COVID. So turns out we just get to be quiet and let the other heroes deal with COVID-19. Now, the interesting patient I want to present to you is a 32-year-old male patient. I saw him in about February this year. He was working as a quantity surveyor on a mine in the Northwest Province. His main complaint was that he had a very painful right eye associated with a severe headache and a fever. He'd already taken himself off for a COVID test, which was negative. He had noticed something floating in that right eye for about 3 days prior to this, a little shadow that kept on moving with his eye. And about a week before this all started, he felt as if something went into his eye. His eye had been red for a few days after that. So I had a good look at his eye. His visual acuity was excellent, 1.2 in both eyes. The intraocular pressures were normal. The conjunctiva in both eyes were quiet, no signs of trauma in that right eye. The corneas and anterior chambers were clear and quiet. His pupils were round and reactive, and he had clear lenses in his eyes. When I looked, this is a color photograph of the patient's right eye, and the arrow is pointing to a small object floating in the vitreous gel just below the optic disc and in front of the retina. You can see the little lesion there with a shadow behind it because it's just off the retina. So when I saw that little lesion, I considered a couple of things. I wondered if it might be a metal foreign body from the mine where he worked, but there was no sign of any trauma otherwise. I wondered if it was some form of uveitis or whether it was an unknown COVID complication, since he definitely had systemic signs of an infection when I saw him. That little lesion, though, was something completely different. It was actually a botfly larva. The botfly usually breeds in the nose and sinuses of sheep. A passing fly will lay eggs on any moist surface, such as the eye. As the larvae hatch, they burrow into the surrounding tissues where they can cause orbital cellulitis or actually penetrate the globe. So this image shows the winding tracks of the larva as it burrowed under the retina. On this image of the fundus, you can see a little hole where the larva penetrated through the retina into the vitreous gel. And inferiorly here is a hemorrhage, also caused by trauma from the larva inside the eye. This is an OCT ultrasound scan of the eye. It shows a fairly normal retina, macula, and optic nerve, but with quite a lot of inflammatory cells in the vitreous cavity. And this scan of the eye shows the retina at the bottom of the field with the parasite floating in the vitreous gel. Now, sometimes in these patients, we would use a laser to shoot at the parasite and to disable it, to kill it. But because this parasite was very near to the optic nerve, I didn't want to make use of that. So the interesting thing about this patient in 2021 is that ophthalmomyiasis caused by the botfly is one of the acceptable uses for ivermectin in humans. Once I finally managed to track down a dose, as the usual veterinary suppliers had had their stocks depleted by human victims, the patient responded very well. His systemic illness settled quickly and the inflammation in the eye settled. He's still aware of a floater present there, but his vision remains excellent. And he was a very interesting patient to deal with. So I hope that this case and some of the other stories give you a window into the interesting world of ophthalmology. Thank you for letting me come and share with you this evening.
Dr. Ophthalmologist, that truly was eye-opening. Thank you. Next, presenting in neurosurgery is our very own Dr. Gerald Mohale. Over to you.
I think Dr. Mohale is currently trying to rejoin and is currently having some technical issues. We will give it a few moments. Otherwise, we may move to the next surgeon until we can sort that out, but we will just give it a few moments to see if he can rejoin us again. We are still having some delays with the process. So I think if we can move on to our next speaker, which I believe is Dr. Satyapal, I think it will give us some time to sort out things with Dr. Mohale.
Hi, guys. Hi, guys. Can you hear me?
We can hear you. Yes, we can.
Great. So orthopedics, always interesting cases, always fun, enjoyable in theater. Can we go to the first case, please, Sudash? Next slide. Sudarshan.
Can you, I've changed, I think there might be a lag. Can you see the chronic osteitis?
Yes, I can. I can see it now. Okay, so my interest in orthopedics started from internship, but this case I remember quite vividly. I was a senior house officer at Whitechapel, London, and she was a Nigerian immigrant, a 9-year-old female who came in with pathological pain in her leg. So pathological meaning there was pain at night, pain, constant pain, medication very rarely worked. Apart from that, she had some sinuses draining pus from that leg. All evidence, x-rays, as well as investigations pointed towards osteitis, which is infection in the bone. Now, this is not very common in the United Kingdom, quite common in our setting. When, as students at Barra, as well as interns at King Edward, we saw a lot of patients with chronic osteitis. So very difficult to treat. We took her repeatedly to theater for debridement, or as the French put it, debridement, and washout of these wounds. But it will settle and recur. So what we decided to do was put a ring fixator, which is a fixator that looks like a TV aerial that's outside your leg. You can see pictures on the right of the screen, and that's a circular fixator. It's not my patient per se. So why I remember this patient, my 6 months rotation at that hospital, she was there for 5 months. She did quite well. And so what was done was the infected bone was resected, and we used the ring fixator to basically extend that bone, or to try and do bone transport to make both ends meet. And she did finally heal. This is information from following registrars and SHOs. Next slide. Sudarshan. Okay, so back to South Africa. my first call as a registrar in orthopedics was at Addington. If anyone knows Durban, this is right on the beach. So every ward has an excellent view of the Indian Ocean. Lots of registrars think they should rather be surfing than working. So this boy I saw on the 5th of January, 2002, he was a grade 11 boy fishing in knee-deep water in Durban Harbor, and he was attacked by a Zambezi. He presented at 11 o'clock in the evening with a mangled left leg. There's a picture on the right as well, not his leg. The interesting thing is the vascular surgeon on call was doing a study on shark bites. So he came in, measured the bites, and found some teeth. We tried for hours to salvage this limb, but it was not viable and had to amputate. Amputation is the last thing we like to do, but life over limb. So we had to save his life, and he's doing very well with the prosthetic limb. Next slide. Sudash?
Sorry, I do apologize for the delay. There seems to be some lag, but can you see the 39-year-old female slide?
I can't, but I can speak about it. One back, yes. So this 39-year-old female I treated 2 years ago. She was a mother of 3, 6, 8, and 10-year-old boys, and she was a teacher at a boys' high school. She had breast cancer, which was diagnosed 5 years prior to her admission, and now presented with multi-organ metastases. So the reason for orthopedic presentation was that she had a fracture of her right femur. She was unfit for general anesthetic. And the good thing about this case, it is a multidisciplinary team involved in her management. So she presented with a large pleural effusion, that's fluid in the lungs for first-year students. For a general anesthetic, not good for a spinal anesthetic because there was tumor in her spine. So we had to settle for regional anesthesia and sedation. And she wasn't even fit to do sedation, whether she would manage and tolerate the sedation because she may need to be intubated. So you may ask, why operate on her? Because she's unfit for surgery. Next slide. So the reason for operating on her, number 1, pain relief. She was in severe pain. Number 2, comfort when being nursed. So she cannot be turned in bed, cannot walk to the toilet, or just do simple things. And we wanted to improve her mobility. The prognosis was not great. I mean, she could demise in the next few days, few weeks, few months, but we have to give patients quality of life. We have to, sort of, if they die, to be dignified when they pass on. And she wanted to go home to spend the last few days with her boys and her husband. So she managed, the operation went well. She went home 2 days later. Unfortunately, she demised a few weeks at home, but we did manage to get her home to spend those last few days with her boys. Next slide.
Apostola, I'll call you back. Thank you.
So here's another good case that a few of you may remember this if you lived in Durban. A South African, this is the actual picture of the aeroplane that crashed at a school just outside Durban Airport. So this was on an excellent public holiday in 2009, September. I was in private practice, not on call, but used to cover one of the guys in private, and they couldn't get hold of him. So I was called to see patients who were injured in this plane accident. I treated the pilot who sustained multiple injuries and a municipal worker who was working on the field. So the pilot initially had, who I treated had fractures of both lower limbs, multiple rib fractures, head injury. We stabilized all the fractures. Unfortunately, infection a few days later. The municipal worker, however, thought that the plane would actually miss him. So he was crossing the field and he thought the plane would go in the opposite direction, but it didn't. And he was knocked over by an aeroplane, sustained pelvic fractures and bilateral tibial fractures. All were fixed, stable, and basically he walked out of hospital, with some deformities, but life intact. Next slide. So why orthopedics? Orthopedics is very interesting. Every day poses new challenges from patients coming with chronic backaches, from malingerers who don't really want to go to work, but also people who injure themselves at work wanting to go back to work. So you need to restore them back to their pre-injury functions. And you see such success, you see success in your procedures when you convert a non-ambulator to a person who is walking, from wheelchair to walking, from using crutches to walking without crutches, from stiff hands to using their hands. And basically you want to see them scoring goals at a soccer match, rugby tries. One of my patients, I was at a rugby match, played for Melbourne Rebels, and at the field I heard a crack and he fractured it. My partner was on call, called me, and we fixed his tibia, and we saw him at, well, the following year, Tri-Nations, we did manage to see him. Treated lots of patients who participate in triathlons. So basically, South Africa being a cycling nation as well, patients falling over, sustaining clavicle, scapular fractures, getting them back to all their sport and passion. And from a patient who won a July handicap. One of our patients we treated a few weeks before the July handicap, and he had a fractured wrist, advised him not to ride at that handicap. And he managed to ride it and he won it. Unfortunately, we did not take any bets on him, didn't expect him to win. But nonetheless, he did win. So orthopedics, I think when you guys finish your med school, you should definitely follow a path in orthopedics. Strong as an ox and twice as intelligent. Thank you.
Thank you very much, Dr. Satyapal. I believe Dr. Mohale is back online and he has a bone to pick with you, being an orthopedic surgeon, as he believes we should follow neurosurgery instead. So next, presenting in special cases is our neurosurgeon registrar, Dr. Mohale. Over to you.
Sorry about that. As usual, neurosurgery is always bumping any other theater cases in a typical day in the hospital. Some technical difficulties there. Able to see my screen? Hello?
Currently, we are unable to see your screen.
It's happening again. I believe you're able to see my screen now.
Yes, now we are. Yes.
Thank you.
Fantastic, doctor.
Right. Yeah. So this is a typical day in the office for me. A lot of things doesn't go well, but at the end of the day, as a neurosurgeon, you make it work. You try to figure it out, as it is important for you to do so. Almost every second being of precious. So I'm going to go through certain cases that we do as neurosurgery, and lastly, I'll then do a very nice case. that shows a bit of innovation in neurosurgery. This first case here is a patient with cervical myelopathy due to degenerative disease that we took to theater yesterday. Basically, the aim here was to do a posterior decompression and instrumentation. So this gentleman came in with central cord. Central cord, usually these patients have called a suspended neurology, meaning the upper limbs might be affected, but the lower limbs could be fine. Very typically seen in patients with osteophytes, and if they do fall, they tend to contuse the cord, and usually they then have this suspended neurology, which they then come and require assistance. And as usual, whenever the spinal cord is suspected to be involved, the orthopeds do have to stay away. He did well, and he's in the ward now recovering. I'm unable to move to the next slide. Is it?
Yes, Doctor. If you open it up in a slideshow, the slideshow icon at the top, you should be able to then just easily go.
Okay, it seems to be loading.
Okay.
Apologies about that. If it doesn't load quick enough, we might have to just load the main case, because I think is what you have from your side.
No stress, Doctor.
Maybe, okay. Oh.
Hi, Doctor. Would you like me to load the main case? Yes, the awake craniotomy.
Yes, please. I'm having a problem. Okay. Apologies about that. Maybe I should take this moment to just briefly speak about my journey to become a neurosurgical registrar. What happened is that I enjoy everything that everybody's afraid to go to. You can call me a daredevil. So anybody dares to go touch the brain, and very few do tend to think neurosurgery is cool and is doable. And based on that, I then decided that's what I do. If it is the most feared specialty, intimidating due to the demand of what is required of a person to become a neurosurgeon, it is what I need to then conquer. And I've been loving it, I've been enjoying it. And you feel like you're on top of the world. It is said that neurosurgeons have an ego as big as nothing else that can measure. But I think it is just if you dare to touch somebody's brain, you definitely dare to have a bit of confidence, which can be confused, as if it's an ego. But it is very much required, because you need not to have a spirit of timidity to do the things that neurosurgeons do. This case here, moving on to this case, I was going to show small cases, but now I'll just go to the main case. This case is an awake craniotomy, a case that we did 4 weeks ago in the hospital of Helen Joseph. It was the first case to be done with an awake patient in neurosurgery at Helen Joseph. To my knowledge, it is the second case to be done in Vets circuit under neurosurgery. Next slide. So this was a case of a patient, 29-year-old, that presented with focal seizures. This patient had no comorbidities, and he had no previous head injuries. So he was giving a history that he did have some symptoms prior, but he was not sure what's going on, as he does not lose consciousness, his focal seizures. But at some point, it prolonged to a point where he definitely needed to come to the hospital for attendance. As usual, patient was with the medical team, and all tests were run on him, including a CT scan, to which we required an MRI to further diagnose this patient. Can we go to the next slide? The following slide, please.
I seem to have changed it on my side. I'm not quite sure if it is showing.
Yeah,
okay.
It's showing. So this is a radiological image, which is an MRI. We call it a T2 sequence, to which shows a homogeneous hyperintense lesion on the parietal region of this patient. So this is sagittal, an axial, a sagittal, and a coronal. And if you remember your homunculus from undergrad, you'll realize this patient is about to be in trouble. However, he did not have any signs with regard to his upper limbs or lower limbs. He only complained of this issue where he has this focal seizures. So he was very fortunate. So finding a patient like this who has this lesion yet no significant neurology, it is for the surgeon to make sure that the patient is intact, even if despite whatever decision of management that it is chosen or recommended for this management. So we then further had to investigate with this MRI and do special sequences to try and delineate eloquent areas around the brain that which, if we are to carelessly transact through, will probably cause this patient some neurology. So this slide here shows where we then had to do what we call, we had to do some diffusion, to which shows us the tracts of the brain and the eloquent tracts that we need to avoid. So what you see in blue on this image is your corticospinal tracts, which are responsible for your upper and lower limb on the contralateral side. So with the lesion being on the left, so the right upper limb and the right lower limb will be in, its conduction will be on this blue tract. And you can see it's more medial to the lesion. And so then we continue to delineate the lesion and point it as red. So that is our tumor. And the blue, as you can see on this image as well, is still your corticospinal. And you have your superior fascicular tracts in purple. And we have the FAT tract, which is your frontal afferent tract, which is responsible for your speech, which is very important for this patient, as the patient is currently, patient is a motivational speaker as well as an IT personnel. So we need to have him go back to work with a good baseline. So very important to note on the next slide is that we need to always speak to family as much as you do your radiological investigations and speak to the patient, but family is vital in these patients, because if you are to operate patients and they come out in a condition that is unfavorable, the patient may not be able to answer or ask you a lot of questions, but family will be definitely unhappy with you. So you call in family, you call in the patient, and in neurosurgery, the family becomes the patient, and the patient becomes just the one who takes the final say. Yet you always work with family, and you can never emphasize enough the risk for they are very much prevalent with neurosurgical procedures, despite improvement due to modern technologies and adjuncts that we add into the operation. On the next slide. So what we then do with this patient is that we demonstrate, we explain everything that we have to do, and we also demonstrate to the patient exactly what the procedure that we have to do or that may save him from further deterioration will mean. By that, what we do is we speak to the patient, show the patient the scans, and show the patient, give the patient the options. And we also show the patient the best outcome based on their pathology. So here we are looking at neuronavigation, which is what we use when we are in theater with the patient, which definitely just gives us on live basis where you're looking at the patient's head, and when you put a pointer, you can actually delineate on the skin and to where the lesion might be. And that helps us to plan as far as to what type of lesion we need to do and which one will give us the maximum resection with a minimal brain injury, if any. So, so this patient here, this is where we had to decide we're going to do the incision, as you can see marked on the pen, and we shaved just around that area. And you see correlating with our navigation 3D system. On the next slide, so the patient here, we did an operation and excised this lesion completely with the patient awake and speaking to us throughout the operation. So basically with these procedures, they usually put the patient to sleep until we position, and the patient is then woken up during the operation. And we have a series of questions to which we ask this patient, and as we operate, we stimulate certain areas to test if they are eloquent to the function. We will ask the patient to move the limbs. We'll also be speaking to the patient and listening to the patient, following the commands of the assistant or an assistant doctor with us, who will be giving the patient instructions to follow as we operate. So knowledge of neuroanatomy is very, 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 very important, as you should be knowing where you are operating and be knowing what you expect to test on the patient for. If you are working on the areas which affect the upper limbs, you need to then be asking relevant questions to the patient to say, move your upper limbs, or squeeze somebody's hand, or raise your hand, or wave. And if it is on the speech areas or speech tracts, you need to then have patients say complex words, complex sentences, to which then test if you are now operating near those areas and avoid extensively operating those areas. So with this operation, it was an operation that was a success to us. From here on, we'll see on the next slide, where the patient is being given instruction, and on the top screen there you see where we are stimulating. I'm not sure if it is clear. So as we stimulate then with the patient, if it was an area of speech, then the patient usually starts speaking gibberish, and you definitely are touching on vital organ there. Unfortunately, from my side, I was going to share a quick 15 seconds video, but due to the technical errors, I will not be able to share the beautiful video with you. On the next slide, you will be shown the post-operative scan, so which shows your axial view. So you just see a remnant of hematoma showing that, and a bit of edema, which just shows that the neurosurgeons have been there. But otherwise, the brain looks well, and there's no injuries to the brain according to the report as well. And this is the patient 2 weeks post-op coming to our clinic, very emotional when he speaks about his experiences and the fact that he's so thankful that everything is intact. He can still use his upper limbs, lower limbs. He speaks very well, and we've maximally removed the lesion. We're still pending histology though, but this was a successful operation, and we are to see many of these types. And I was grateful to be part of the team operating in awake craniotomy, as it is currently now the Transat. So that is it. Thank you very much. This is what I do. I fix brains. That's what neurosurgeons do. Thank you.
Thank you for the lovely presentation, Dr. Mohale. Finally, we move on to our last panelist presenting on special cases, and that is urologist Dr. Salim Chinara. Over to you, Doc.
Yes, thank you very much. Appreciate that. Yeah, just before I get to my cases, just was reminded about something quite amusing in the male change rooms at Charles Makeke Hospital. While you're in the change room doing your urology thing, one of the cubicles, there was this thing inscribed on the back of the toilet door, and it said double-blind study. What's a double-blind study? 2 orthopods looking at an ECG. So that's still there. I wonder if it's ever been removed from there. Anyway, I chose these cases because all of these cases are pretty life-changing post-operatively. Obviously, we do many cases, but I wanted to single out just a few cases just to demonstrate some of the things I wanted to for tonight's meeting. The interesting thing, though, also is that once you've completed your training and your fellowship, really that's just the beginning of your learning curve. The sky's the limit. You can involve yourself in so many different avenues and training programs, fellowships, spend time with experts in the field, and literally skill with your eyes and acquire the skills necessary to practice your art. So that's the amazing thing about surgery. It just continues to give. Okay, so the first case is a 22-year-old male. This guy was it was a gunshot wound pelvis with a pelvic fracture. There was also a blast injury that involved the penis itself. Almost one half, or I would say pretty much, maybe just slightly less than 50% of the one side of the penis was actually just blown away. This was a hijacking attempt. And the urethra was actually visible from this injury that the individual had. So initially, he underwent a penile reconstruction just to at least get some decent shape from the penile to cover the distal urethra. There was also a massive open urethral. He also underwent a massive open urethral reconstruction to finally basically deal with the problem. So just to give you an idea what we were dealing with. So if you look at this picture, that was basically the pelvic fracture. The whole left side of the pubic vein was blown to pieces, and that just gives you an idea what this is a VCU. So what you see, the white color there is the bladder, and that part that comes on is just the proximal end of the urethra, almost like at the level of the prosthetic urethra, and then there's nothing in between here. It's completely gone. And then if you look at this picture here, okay, you can just see about the remnant of the contrast that we eventually drain out. So this again shows you the distal end. So as I showed you in the initial picture, the bladder would be sitting somewhere there on top, and there was just a little sort of a mark of a urethra there, and there was a gap in between, and this now is the distal urethra. So we inject contrast from the penis, which is there, fills up that urethra, and it stops there. So the defect is probably from that point, probably up to about that point, which is quite a large posterior urethral injury. And initially, what we attempted was a urethral alignment. So we put a camera basically through the penis itself and see if we can see the proximal end. If we do, then we put a guide wire in there, and we can obviously create continuity between the proximal and distal ends of the urethra. But that was not possible because of this massive defect in the posterior urethra. And when we put our camera in here, we just like enter the space, into the cavity with numerous blood clots and just shrapnel all over the show. So the plan was obviously just to leave a suprapubic catheter, which is a catheter that goes basically just below the belly button, above the pubic symphysis. A drainage tube goes in there to drain the bladder temporarily. And we wait about 2 to 3 months until all the swelling, everything heals, until we then come back for the final repair. And it was interesting, during this time, this case it was very interesting, and I just thought to myself, who can I involve? It was just about the time I'd finished my specialty training, and trying to look around some of the maybe a bit more experienced urologists who would be willing to assist me with this case or get involved in. Guys are not really that keen, saying the results are not that good, patients are incontinence and don't really get involved. And just around that time, I was attending a conference at Sun City. It was a urology conference, and there was a professor from India who was invited from the Kulkarni Endosurgical Institute in Pune, in India. There's a little city tucked away not far from Mumbai. And, he presented these cases, and I was just so amazed at seeing what he was doing. Reminded me of the case that I was sitting with at the hospital, currently. And after the presentation, I went up to him and said, I'm just quite amazed at your results. I mean, they're quite phenomenal. And he said to me, you know what, come see it for yourself. And when you're in India, anytime, join us and come pay us a visit. And I took him up on that challenge, and I spent a few days at this institute, and I was amazed at what I was able to learn there. Very, very humble sort of place, but amazing what these guys are actually accomplishing in their theater environment. They got special areas where they house the patients in special rooms, and they got excellent facilities where they sterilize the equipment, etc. And after acquiring the skills in this institute, I was able to attend to my patient, and I'm happy to report that we were able to completely reconstruct the posterior urethra. And after the healing phase, he was able to urinate without any problem, and his continence was also well preserved, and so was his erectile function. So it was an amazing result, and just highlights the point that the sky's the limit in surgery. You do what you need to acquire the skills to change the lives of the people that you come across. You can't change the world, but you can certainly help and assist those that you come into contact with. My second case was a 5-year-old boy was referred by a colleague from Zimbabwe who had a hypospadias and underwent reconstruction in Zimbabwe. So that's what a hypospadias is. That's what a hypospadias is, where there's a defect basically in the urethra. So he was actually urinating from an opening there with this whole wide defect sitting in the urethra. And there was an attempted repair in Zimbabwe, but then what happened is the child developed complications, and he developed numerous fistulae. So they eventually managed to close the urethral defect, but then he had all these little holes through which urine was actually coming out. There was actually something very, very close to the scrotal area as well, almost what we term as a watering can perineum. And as I said, one of my interests is urethral reconstruction, something which I also acquired while I was spending time at the Kulkarni Institute. And what we did was, basically what we did was just find the defect, as you can see there, open up the different layers, and then initially debride the opening. You can see the catheter sort of in the distance in the background. And what we do after we do the primary repair, we also use a flap just to ensure there is a good blood supply to the area. And then we had actually a very good closure. This was actually a very, very good result. The catheter stayed in for about a period of about almost just over 2.5, 3 weeks, just to allow for healing of all the fistular tracts to close. And I'm happy to also report I recently saw the child. This was after about 3 years from the surgery, and he's urinating well. And this has done a great amount of help for his self-esteem, because initially he was scared to go to school. He wouldn't want to be in the change room with other young boys. So again, speaks to the mental health issues that come about, with these kind of sensitive anatomical areas in the human body. And and the third case is a 27-year-old female. Was referred having discovered a right flank mass. She was also referred from North Africa, and she came in basically with the CT scan, which showed a huge, large right-sided mass to such an extent it was actually extending into the right renal vein, or what we call a tumor thrombus. And this was almost literally the size of the kidney. It was measured about 14 centimeters. And the most amazing thing at this stage was that all our tests to assess for metastases didn't reveal any metastatic disease. Obviously, because of the age, and our approach was to be as radical as we could be to remove this. We did a open radical nephrectomy, and also by securing the IVC proximally and distally, we managed to open the renal vein and remove this huge mass, which thankfully had not gone very, very proximal into the inferior vena cava. It was almost like floating in the inferior vena cava, and we managed to remove that. So that's actually what we had. This is huge right renal mass. There's the liver on the top there. You can see this mass sitting there. That's the kidney, and this basically is the IVC. So this mass, the tumor thrombus, extended into the renal vein, and now it's extending up the IVC. And there's different levels. So it's subhepatic, it can be intrahepatic, and obviously it can be a suprahepatic, which obviously could require cardiac bypass to actually get to that level. But thankfully, this was subhepatic, and we managed to completely excise the tumor and its associated thrombus. You can see it similarly, there's just blown up as well. So there's the thrombus that goes into the renal vein and extends up into basically the IVC, which is about somewhere there. And we had actually an amazing result. And this is now about 5 years later. I've seen her; she's completely disease-free, cancer-free, and literally living her life, an amazing quality of life. This was a recent MRI we took on her at one of her recent visits. So the picture I showed you earlier on, you can almost see now that there's a cross-section of the liver, and there's absolutely no recurrence of any tumor. There's no even lymph nodes. She got a normal, healthy kidney, and living her life, to the best. Quite an amazing result in a young person. It's almost certainly life-changing, and makes this job and this ability of surgery generally very rewarding. I think as much as we are competing, but surgery has that dimension to it. There's a great sense of of satisfaction that comes out of it. And you almost feel it almost feels like you have this ability to get involved with the human body, which is so sacred. And you're allowed to explore its deepest crevices, and you're allowed to get involved with the amazing creation. And those are really special things about surgery. As I said before, it's that time in surgery, the time in theater, that it's really what it's all about. It all comes together there. And so surgery is an amazing discipline. Thank you.
Thank you so much, Dr. Chinera. I do agree with you that the human body is sacred, and I think in your special field, you're definitely dealing with maybe a few more parts that could be considered more sacred and more private. I just want to thank all the doctors for giving honestly a fantastic summary of cases that they thought were honestly rare in their lifetime and experience. Currently, we are going to be going on to our next round. All right, and I was thinking that if our very own neurosurgeon, Dr. Mahale, had to operate on me, he might find me pretty special as well. He might find it pretty easy, because I've been told I have quite an open mind. So the good, the bad, the ugly, and the special. I am referring to the cases, mind you, and not the exams that we've been writing, because they can only correlate to the bad and the ugly, unfortunately. The knowledge provided by such rare cases is honestly invaluable, not only serving as points of interest, but also points of education for our viewers, irrespective of their occupation. I think no matter what profession you're doing, however old you are, it's important to discuss some of these things. And it's important to be educated. I remember when I was small, talking about plastic surgery was prohibited. Someone would mention Botox and no one would raise an eyebrow. But now I think this leads us to our main event, round 3, where a set of questions sent through by you, our beloved audience and viewers, will be answered and debated upon by our speakers. Sparks usually fly in this round, which is more than I can say for every Eskom power plant in this country, which by God's grace have let us proceed tonight. Voting lines will be opened after this round, and some of these questions do fall under the Wits Student Surgical Society's underlying theme of confronting contagions. And so with that, I would like to hand over to Priyanka, who will aid in presenting the riveting, spellbinding, and questions that have been sent through. Just before I hand over to Priyanka, I would just like to explain this round to both the audience and our panelists. So basically what's going to happen now is that you will all switch on your cameras and you'll all be unmuted. And Priyanka is going to be reading to you the questions that have been sent through. When she asks a question, whoever wants to answer must just raise their hand and she will choose who to answer. Obviously, everyone is entitled to answer to a question, because that is the whole purpose of this debate. And so thank you. Priyanka, you can take it away.
Thank you, Sudarshan. So as mentioned, our theme this year is confronting contagions. So I thought I'd start by confronting one of the most prominent contagions that we have, one of the most prominent social issues that we have in South Africa, and that is poverty. So respected doctors, our viewers would like to know, how do you help with issues like poverty in South Africa? And how do you, as a surgeon, as a doctor, try to uplift the underprivileged communities in our country? Dr. Chinari, you may answer.
Yes, thank you. That's a very good question. And whenever you enter medicine, you always feel like you need to change the world. You want to make you're gonna go there. You're gonna make it all work. And I think you quickly realize that you're better placed. And certainly with my experience, I feel like you do a lot more when you ensure that those people you come into contact with, that you can try and change their quality of life and make that better for them. And that's very, very rewarding. So yeah, so to answer the question about outreach programs and how we try to deal with underprivileged communities, you mentioned in the introduction. So more recently, I was involved with the Mask for All Africa campaign, which was a campaign where we were trying to assist in local communities, women in their homes with sewing machines to sew masks and providing them with materials and a distribution way to get it to underprivileged communities. I'm also involved yearly with the Lenasia Cancer Society, where we do a prostate cancer screening program. And one of the laboratories that I'm involved with in the hospital, they sponsor about 100 or so free PSA blood tests. And I usually give a talk at this event, and then we encourage patients to be aware of prostate cancer and how to approach that situation. I'm also involved with the Islamic Medical Association Clinics Committee, where we provide, so this is more primary healthcare to disadvantaged communities, and we provide medicine also, which is all sponsored, by community leaders and other NGOs that we work with as well. So, obviously, and also in working with these NGOs also, as far as religious leaders are concerned, community leaders, those that are not on the medical aid, we're often involved in where we provide our services without charge, where certain individuals may not have a medical aid, but they may have some sponsors, and that we have agreements with certain hospitals where they reduce the rate of the theater time. And in so doing, we can assist them, by helping them with surgery at no charge. So these are some of the things we do. And obviously the medical male circumcision program, which was quite big in South Africa. And as registrars as well, we were involved, in assisting some of these local clinics. We would go out and assist the nurses and even some of the male nurses, as well as the sisters as well, to acquire some skill and ability to do these circumcisions in their local communities as well. Thank you.
Thank you very much for that, Dr. Chinari. That really is so inspiring. And I am glad that we have surgeons like you in our country. Any doctor liking to take him up on that, believing that they do more to uplift? Dr. Jenny Lathwaite.
I think ophthalmology has an advantage because cataract surgery is one of those projects where one can quite straightforwardly make a plan to get into a community and assist with cataract surgery in a fairly contained kind of a way. So, from the time that we're registrars, we participate in what are known as blind tours, where we go to rural hospitals. There's a fairly container-based kind of ophthalmology theatre setup. And within about 2 days, we can do between about 30 and 40 cataracts for patients in those areas, which is something that it's about as close as you can get to instant gratification in surgery, I think. Ophthalmologists generally operate a program called Right for Sight, which enables doctors in private practice to add non-paying patients to their theatre lists. And that's a way that we're really able to add some of those patients in so that we can do them. It's a funny thing, but ophthalmologists, I think you won't find many ophthalmologists who don't want to do cataract surgery if someone's willing to help the patient get there. So there are a lot of projects that we get involved in. I also mentioned Flying for Life, where we specifically go up to Donald Fraser Hospital in Venda to do cataract surgery. And we sometimes do some other surgery there as well, but that's the one that we usually target in terms of the good outcomes it can give with quite a small input, which is great to be able to be part of.
Yeah, that's great. I mean, the site is an amazing thing to accomplish, and I think that surgery in general, that we make life-changing, approaches to our patients. Yeah. So, as urologists, we deal with very, very important organs. So the kidney, an amazing organ as well, and when it fails, it's really problematic. And so, also with many of our NGOs, we're involved in situations where we have these dialysis programs as well, and if you look at the waiting lists that are both available in the government sector and in the private sector, and what we do, we select out individuals that may not can't afford it, And to some extent also we have guys that actually contribute to medical aids of individuals, you know. So we get them onto a medical aid, so at least even if they've been excluded for a year or so, at least a long-term solution for them is that they will be able to get onto some sort of dialysis program. And this is life-changing, you know. I mean, if somebody, you know, has renal issues, it affects their quality of life dramatically, you know. And just by offering a service like that is definitely very life-changing. In addition to that as well, obviously, urologists also work closely with nephrologists, and that also speaks to the transplantation program as well. And you know, if ever you were involved in renal transplantation, as I showed you the picture there of a kidney and what the size of a dialysis machine looks like, and somebody who has to spend their lives maybe 3 times a week in a dialysis institute, and they can't even do any work. They're tired, they're exhausted. Their quality of life is very, very poor. But renal transplantation is an amazing gift that one can give. And you know, urologists are also keenly involved in that as well. And again, we do this also through NGOs, where those that can't afford it are also you know, assisted by many people out there that are willing to contribute and make a difference in other people's lives.
Thank you very much for that, Dr. Chinara and Dr. Laithwaite. Do we have any further contentions? Dr. Chen, over to you.
Look, I don't want to blow my own horn here, but on the failing organs that's happening in our society right now is probably the public health system. And in the public sector, you know, as you all know, our hospitals are under immense strain, especially with the whole pandemic as well. And, you know, we are the only department that actually makes money to supply the hospital with more funds, considering, you know, we charge for our plastics procedures. So I would think that, you know, it's kind of important for us, and that is a very worthy organ to support right now.
I don't think we were asking about revenue generation. We were asking about poverty and access to poverty.
Can I just do a rebuttal there? Is that I think poverty is a condition that's, you know, has a complex relationship with poor access to health and level of education. So, you know, we are solving one of the problems, if not all of them, you know.
Urologists were voted the highest paid profession in America. Okay, I think South Africa will lag a bit behind. So yeah, when it comes to revenue generation, I think we're up there as well.
Thank you, guys. I believe Dr. Satyapal has raised his hand as well.
Yeah, hi guys. So any patient who needs to go to the urologist or the ophthalmologist needs to walk, and they need to get there. So my practice have supplied wheelchairs, crutches to both orphanages as well as to old age homes. And as a practice, we do treat patients pro bono. Surgery can become difficult to take them to a private hospital, but we do assist in the government hospitals. And in orthopedics as well, we went often with the Red Cross to rural areas. Listen, you can't really operate there doing orthopedic procedures, big procedures, but we do refer them to the local centers to come in for their either to correct deformity correction. Unfortunately, waits for joint replacement in any hospital is quite long, months, sometimes years. But we're not at that stage where it's similar to the NHS in the UK, where the wait in the government hospitals can be shortened by patients being done in private. So I think that's the way to go, where everyone gets on board, companies, prosthetic companies, doctors, anesthetists, and the hospital itself get on board to provide the service to decrease that wait list. So we are waiting for that to happen.
Thank you, Doctor. I would like to hand over to our last contender, that is Dr. Mohale. Over to you.
Yes. Unfortunately, neurosurgery does not necessarily bring revenues or have a big number of people to go do outreaches. We are almost always short-staffed on an everyday basis. But then what we we do in VETS as a neurosurgical unit. We are establishing small sectors of neurosurgery. Believe me, it is almost impossible because neurosurgery requires certain instruments which can only be found mostly in private. If they are to be if they are to be considered to even be part of hospital in government, it usually takes decades. But I've seen from the department that they're really making sure that all the small hospitals now do serve or do have some basic neurosurgical attendance to patients. As far as Northwest, I think that's as far as we go, and we take the entire Northwest. And in our sector here in Gauteng, all the small hospitals do have a system to which they do get access to neurosurgery. Very much overloaded. So what happens in Helen Joseph is that usually we have these weeks that we do call in patients that we know they really need neurosurgical intervention, and because we know they will not get it anywhere else, unlikely that anybody who does not have a medical aid can do any procedure neurosurgical procedure in private and still remain financially sound. So we do call these patients on a weekly basis, where we create these weeks. We can call it a pituitary week or a tumor week, to try and unfortunately relieve these patients from the burden to which no one else, rather no other system is made to resolve. And it's very difficult to get donations. Even when we're doing it under government, we usually do it with the government resources, because it's very difficult to get funding for neurosurgical cases. As per case, it is very expensive, very costly, and most of the time you can only do one case per day, as our cases are very long. One other thing that we do usually when patients have, most of the patients can afford to go to see a general practitioner, get a CT scan, and from there, there's nothing else that their money can afford going forward if it is a neurosurgical diagnosis, and it's a serious issue in South Africa, where even when they come to government, it takes them forever to actually come to a point where they are assisted fully. And this is an organ that is vital. I mean, if you lose your arm as far as you can't use it, you might as well be as serious as somebody who comes casualty with an arm that is almost threatened, if something in your brain is threatening that function. But it's not necessarily being prioritized in that manner yet, but we think it's something that's going to change. So what we do with patients that come from private with lesions, usually they then need an MRI, which is almost 20,000. We then organize them agent MRIs based on, we triage, of course, because we don't want to overload the radiology department, which is already overloaded as well. And we try and speed up patients that have been waiting in queues or in the waiting list from our biggest sectors like Joburg, Jen, and Barrow. We are far from probably doing the significant difference, but we're pushing. We are unfortunately now being bothered by COVID, that now we don't even have ICU, because all ICUs, all vents are occupied, and no neurosurgical operation probably can be done safely and confidently without the ICU or ventilator bed. So it is quite critical, to which maybe we will probably improve and come to the levels of other disciplines with regard to the type of charity works or assisting of disadvantaged people. A work in progress indeed. More needs to be done.
Thank you very much,
Thank you.
Dr. Hale. That concludes our first question. So allow me to move on to our second one for the evening. We understand that we are still dealing with this issue of confronting contagions, and another one that we have in South Africa is mental health. We understand that mental health issues have been elevated, especially during the pandemic, due to a number of reasons. So our viewers want to know how your surgical specialty, how it considers the mental health of the workers or professionals in that field, firstly, And secondly, how the mentality and the psyche of patients are adjusted after being operated on, after surgery is performed on them. So to sort of refine my question, both how mental health of the professionals are considered in your surgical field and how your patient's mentality is affected after surgery. What are the impacts of the surgery on their psyche, on their mental well-being? Dr. Mohale has his hand up. No?
Yeah.
Okay.
Can I continue?
Please proceed.
Yeah, my quick hand was on the basis that, I mean, it is just a recent topic. I was speaking with my colleagues and other fellows in other departments on the basis of interaction as colleagues with regard to how this COVID has actually changed things, even how we now view patients, triage patients, how quick we need to do things. We always think COVID first before patient. It is becoming a very serious issue, to which now, even if you have to save life, you first think, am I safe to approach a patient? So our minds have been set to now think COVID before thinking, what am I first? I'm a doctor, and unfortunately, I work in serious threatening situation on daily basis. COVID is one of the new things that are in fashion now, but there are other things that we've been afraid of before, like HIV has been there. You know, you're busy taking blood. Half the time, most people take blood even without gloves, but before it was just a taboo, like you don't want to take patients' blood if you think they've got stigmata. I think it's very serious. The issue, the interaction between doctors now, when you want to speak to an anesthetist, first they want a COVID result of the patient before they care whether the patient is dying in the few minutes or not, and it's frustrating. And you see it on a day-to-day basis. If you are a surgeon, especially amongst the colleagues, maybe they will agree with me that if you have an emergency, for those who have dire emergencies, you can't think COVID before patient. If you do, you usually lose time. For those whose specialties have time become a very important factor. Now, for patients, what we see now is that I think we need to anticipate a lot of complaints from mostly in neurosurgery. We know family, as I've alluded in my presentations, that family is an important factor of managing of your patients. So with COVID restrictions now, your patients stay forever in the hospital, undergoing either reoperations or therapies of all sorts, post-op or pre-op. And families can't even visit them. So mentally, the patient deteriorates. You see it in the patient longing for their family members, and the families are also anxious, for they can't see the patient. They don't know, they don't see the progress of the patient. They can't come to the hospital. They can only depend on telephonic updates, to which also are not very practical in a hospital that is overloaded. How many patients, families are you going to call per day and see patients when and operate when? It's a serious issue that was never anticipated, and there's no plan for it in any institution, even in high institutions, even in private. I think that there's those challenges which then they can be, they were never planned for, so there's no measures to sort of mitigate them any better. Everybody's trying to do their best, but yeah, serious concern indeed.
Thank you, Dr. Mohale. I believe Dr. Jenny has had her hand up for a while. Proceed to you.
Yeah, so I think you raised such interesting points, Dr. Mohale, and I can really identify with what you say about COVID in the hospitals at the moment. I was saying to someone today that it's funny how it's not the first time we've dealt with an infectious disease as doctors, and yet somehow we're quite paralyzed sometimes by what we need to do around COVID, and we really do have to take it so seriously. But in another sense, we do actually have ways of mitigating against a lot of the risks that we deal with. And sometimes I think we have to not worry so much about the COVID results and take the appropriate precautions and carry on with what's really urgent. In terms of mental health of health professionals, yeah, I don't think doctors and healthcare professionals generally have been good at taking care of their own and their colleagues' mental health. I think we generally assume that that's something that you need to sort out and come to work in one piece and put together neatly to be able to do your job. And I do think that it's something we need to learn a lot better. To be able to set up a working environment where doctors aren't expected to be heroes at their own expense all the time. I think it's really important for us to find ways to do that, and to build a fraternity of doctors that does support one another and recognize the real risks that doctors face in terms of their mental health from day to day. We too often hear of doctors who reach the end of their rope in terms of being able to carry on with their work. And then the other part you asked about was the patient's mental state after surgery. And I think it's such an important question to ask. I think one of the times that we see it most often, and for us, it's often in cataract surgery. And one of the difficulties of having an operation that is so successful is that patient expectations are extremely high. And so much of the preparation of a patient and how they will feel afterwards depends on how the expectations that you give them before surgery. It depends on an absolutely thorough pre-operative assessment. As much as our skill in surgery is critical, if we have made promises that can't be kept because of underlying issues that we haven't recognized, then that patient is not going to be happy after the procedure. When we promise miracles, we have to be very clear with patients. Are they going to need to wear glasses after their cataract surgery? What will they be able to see? Do we think they'll see immediately on the first day? Is it going to take a while for the eyes to settle down? Are there underlying issues that we're still going to need to deal with? And so much of the place we can get into danger as surgeons is when we don't give correct expectations to the patient. Sometimes under-promising and over-delivering is a greater benefit than making promises we can't keep to people. And really, letting them go into that theatre with an appropriate expectation of what is possible.
Thank you, Dr. Lathwaite. I think that was beautifully put, and I agree with every point you brought up there. Dr. Chinara has his hand raised as well. Would you like to intervene there, Doctor?
Yes, thank you. That's a very, very good question. And your question basically was asking about how each field considers the mental health status of first of all, their professionals, their workers, their staff, and then finally the patient. And the simple answer is that they don't. That's the reality. It's not like that. I think it's the way we were schooled. When you were registrars, you just carry on working. You don't worry about when the next shift. You can work 36 hours, or so carry on, have a short little nap, and you're back in the ward round, and you're back in theatre, and you're back here, and you're back there. And that created a problem. It created this mindset that you just can continue going, and the exhaustion that comes with that. And the mental health strain that comes with it is often hidden because the next day you're expected to be functioning in a clinic or in theatre or while you're consulting with patients. It's that responsibility to an individual that you feel like I need to push myself. I can't go there and say dumb things or start slurring and doing the wrong thing. So you push yourself to that level. And the interesting thing about that is that with this pandemic, and I find it quite interesting how we can tie up that mental health status or state with the current pandemic, because what I feel the pandemic has done, it has almost exposed those cracks in the system, where because of the strain that this pandemic is bringing to the health sector, you're starting to see people crack under the pressure. They just can't do it anymore. They just sort of, you can just recognize where people have had enough. They can't take it. They're not managing. They break down. They become emotional. Tragically, we lost one of our colleagues last week, who after about 35 years of service, committed suicide in his rooms. It was unbelievable. We're still trying to get over that state. And we ask ourselves, but we saw the guy the day before, did we not recognize any signs? And that's just it. As a health professional, you're hiding all of those signs. Maybe because you know what you shouldn't be presenting to people. You don't want people to attach a stigma to you or whatever it may be, and you're just continually working. And I think that's very dangerous. So the simple answer is no, and a lot of change to come to that. The issue around patients, I just find that, again, we can tie it to the current pandemic. A well-informed patient, a patient that understands what they're going to go for, what the procedure is about. Nowadays, with access to videos and access to recordings, you can show someone the detail of what you probably plan to do in theatre. And I just find a very well-informed patient is a less anxious patient. And then again, talking to the team I showed you early on, when a patient enters the theatre environment, the way they interact with your staff and with your team is so vital to calm their nerves and to make them comfortable, and obviously how you deal with the patient post-operatively in the ward. And most importantly, I always say to my family, I'd never ever switch my phone off. It just goes maybe between the silent mode and the on mode. Because especially if you're in a surgical field, if you operate on somebody, the responsibility, they don't want to get hold of somebody else. They want to speak to you. If there's a problem, they don't really want to contact anybody else, especially when you're in the private sector. In the provincial service, you get different guys on call, and so they'll accept that they can speak to somebody else. But if you work between the two environments, you have to always be available. And I think that helps settle patients when they can speak to you, or nowadays with social media, even just a simple text message or a WhatsApp can relieve their fears quite significantly. So yeah, you're right. I mean, mental health issues and the pandemic definitely going together, no question about it. Thank you.
Thank you, Doctor. I appreciate the honesty there in that when you said that sometimes specialties don't really consider the mental health, and maybe going forward, it's something we should look to implement in our health system. Dr. Satyapal, anything to say on behalf of orthopedics there?
Yes. So during the first wave, orthopedics, all specialities was quiet. Elective slates came to a halt. Patients stayed at home, so there was no trauma. So during that time, I volunteered for COVID helpline, doctors on call. And we used to get numerous calls, and most of it was basically addressing patients' mental health. Lots of them just wanted advice, whether to get tested. And I think there was mass hysteria to get tested. Every little symptom you had, you wanted to get tested. At that time, there were not enough test kits. And you just had to basically sort of calm patients down. And then you advise when to get tested and when not to. So that continued until the end of August. They wanted to start it up again with the second wave because another mass hysteria, but that didn't come into fruition. Also during that time, in January this year, a colleague of mine, we did registrar time together as well. He was an ex-partner of ours, passed away, very young guy in his late 40s. I was depressed. And then it so happened that same night, another colleague who also was with us called me. I mean, it was midnight. I was actually self-isolating because I had COVID as well. And it was quite severe. But with colleagues calling you every day, you sort of, they put your mind at ease. And when you never answered that phone, crap, they thought you were dead. So, I mean, our sats were sitting at 84. And thanks to colleagues helping out with medication and oxygen concentrator, we did well. And then another colleague passed away at my hospital, 80-year-old orthopedic surgeon, still on the call roster, but he didn't work for money. He just wanted to come into work every day because doctors, sometimes they don't plan for retirement, one. Number two, they just want to come to work to chat to friends. Because when you sit at home, 80-year-olds become 19 overnight. And he was a fit guy, last person to leave the party. And the first December he worked was last year because I had COVID, I couldn't do the call. And I think that's when he got COVID and he passed away in. Sure. Sorry about that, guys. In Jan. I'm going to go off now.
Dr. Satyapal, I'll allow you a moment. That surely was very moving. For the sake of the presentation, Dr. Chen, would you like to give your response while we wait for Dr. Satyapal?
Sure. So I think there's a few things that, I mean, COVID is the main topic of this whole mental health awareness thing. But I think from my perspective, or in our department, the questions posed, well, firstly, do we do enough for our colleagues and, you know, in the department? And I think the answer, as everybody has agreed, is no, we don't. And especially in a, discipline like plastic surgery, where for us, you know, firstly, you wait forever to get a post, and then now you're working, you know, through, and then, you know, you go through stresses of exams and everything, and nobody's checking on you all the time. So I think, you know, as a department with our fellow registrars, we had this thing where we were like, you know what, it's important to constantly check up on your colleagues, make sure they're fine. Because, you know, you will get lots of colleagues saying to you, you know, oh, like, you know, things are tough, but, you know, at least I got a post and, you know, life is amazing. And, you know, as much as that sounds like they're just joking and trying to convince you, but at the same time, they're actually struggling with their own mental health disorders, and they're trying to convince themselves. So constantly, you know, telling people, but, oh, at least I'm one of the lucky ones, is like their way of, you know, like reinforcing it in their own mind. So, you know, from my own experience, you know, going through it, I think the first thing is to, you know, especially for the future doctors in this seminar today, it's important for a few things. One is that don't try to control what's uncontrollable. So, for example, don't plan your life in the way of events or things that you have no control over. For example, you know, you'll get married at a certain age, you have kids at a certain age, you want to start specializing at a certain age, because none of these things are in your control. You know, it's very much a, if your opportunity comes up, then it happens. I mean, just because you have all your exams doesn't mean the next registrar post opens is going to be for you. And, you know, planning for it means that you are setting yourself up for failure. The second thing is, and, you know, everybody always aims for happiness. And don't set your happiness on achieving something. So, for example, if I become a specialist, I will become happy. Look for your happiness first before you go onto that route, because you'll only end up, you know, feeling empty by the end of it. Then thirdly, what was my third point? I can't remember now. Oh, right. So, like, I think what everybody has spoken about already was one of the consultants in trauma. Actually, you know, we had a chat, and he was saying that, you know, it's not about who has mental health, you know, disorders. It's about how good everybody is at hiding them. I think that's actually very important to know that you're not going through this yourself. And, you know, there's plenty of colleagues around you who are probably feeling the same way because they're going through what you're going through too. Then, sorry, just the last part is the part about, you know, mental health and patients. So, my sister's a psychiatrist. It's a bit lighthearted, but yeah, I always say to her, you know, I'll put more smiles on faces than she does. And, you know, I sometimes wish that there's a word to describe the feeling I get when I see a patient, you know, looking in their own reflection and, you know, is actually happy with their self-image. You know, that is pretty rewarding in itself. But yeah, lastly, another fun poke at everybody is, you know, again, about bringing more income into the system means more employment for psychologists and support for therapy for doctors, and also more ICU. So everybody else's problems will be sorted. So don't forget about us when you decide if you want to refer patients to private or to send them to a government hospital for a cosmetic procedure.
Got it. Thank you. Thank you so much, Dr. Chen. Firstly, I'd like to extend my condolences to Dr. Satyapal. Have you concluded with your answer, or would you like to round that up?
I'm okay. I took my mental health medication, so I'm fine now. So basically, to the students, choose a specialty that you're going to enjoy going to work every day. You don't want to dread going to your rooms and think, crap, another day, you know. I mean, and that's one. The second thing as well is mental health for patients. Like Dr. Chen, always we want to see smiles on our patients. But during COVID, all the waves, lots of patients waiting for elective surgeries, their deformities and their problems mobilizing became worse, or any medical problems became worse because they were scared to go to the hospitals, scared to do consults. And telephonic consult, yes, it helps sometimes, but you need to see the patient. So when surgery started again, I think that also sorted out some of the mental health, because now they could start to walk. For urologists, maybe start to pee again. For plastic surgeons, more smiles. Ophthalmologists, more people can see better. So I think with surgery and elective work starting again, we sort of lifted people's spirits up. So I think that's very important. I mean, yes, we all need to sanitize and mask and, you know, social distance, but medical care has to go on. And yeah, that's about it. I mean, this is going to be around for, I don't know, years to come. So we need to deal with it so that we continue. Everyone has COVID fatigue. We need to take time off. And, you know, when you feel that you have burnout, just take that time out. From student to interns, you just need to take time for yourself and for your family. Okay, thank you.
Absolutely. Thank you, doctors. I think our eyes truly have been opened to the important thing. And as much as each of your specialties are renowned for so many things, I think definitely mental health is one of the things that we need to take a closer look at. But of course, I'm a student. I can't implement that just yet. But I do believe that implementations as such are in progress and in good hands. Based on the feedback I've received from you guys. That does conclude our round 3. Thank you guys for your responses. I would now like to hand over to Sudarshan.
Thank you guys. That was fantastic. Honestly, it was the intensity levels and the spice levels were seriously reaching new heights there. And even our beloved orthopedic surgeon, Dr. Satyapal, had to take a little breather. But I'm glad online resus is working and we have him back. So yeah, I think it's about time we put the boxing gloves, or I don't know what you want to call it, forceps down. With all the years of expertise, hard work, intelligence, astuteness, and words overflowing on this virtual platform, Zoom might be in need of a little triple bypass just to continue this event. And in that case, maybe we should have gotten a 6th surgeon, a cardiologist, online. On that note, I do think it is time that we open up the voting polls for whichever specialty or surgeon the audience and attendees thought presented best. Voting lines have now been opened and will close shortly. So, you know, make your votes. You don't have to be 18. Good luck. Okay, while voting proceeds, I do think it'll be good to go to our annual giveaway in the Great Debate. Now, we'll be gifting one extremely lucky viewer with a set of their own scrubs. And so a massive congratulations to Danielle Olivier. I trust you will enjoy your set of scrubs and hope it serves as a memoir to this amazing evening. And, you know, I was saying that we don't have a cardiologist here, but Danielle, all is well if you receiving these scrubs means that No Scrubs and Wit Surgsock has a good place in your heart. And with that, I will now be handing over to Priyanka to announce which specialist in all their surgical glory proved a cut above the rest. Thank you, Priyanka.
Ladies and gentlemen, voting lines have now officially closed, and we are just about ready to announce the winner of the evening. Before I do that, though, I would like to commend the speakers for making this event so truly special and for elevating the status of our very famous Great Debate. While there is only one winner, I'm certain every attendee can concur that each and every one of our speakers tonight have been brilliant and awe-inspiring and so much more. And as the saying goes, it's not the size that matters of the scalpel. Rather, it's about the size of the incisions you've left etched in our hearts and minds. And so, without further ado, the winner of our annual Great Debate is Drum roll. Our plastic surgeon, Dr. Chen. Yay. Round of applause, everybody. Congratulations, Dr. Chen. Is someone wanting to, would you like to give your acceptance speech?
I'm allowed an acceptance speech.
Absolutely.
So I'd like to, thank everybody. I think, gonna definitely gloat this on social media for all my colleagues and other specialties. No, I'm joking. Like, I think, on a serious note, is that, medicine is a team game, and at the end of the day, without each and every one of you, and all the other specialties, we won't be able to provide what's best for the patient. And, plastic surgery is a specialty where we rely on other specialties to, do their job, and we help them complete their part. So, I think I would also like to thank all the other specialties for all they do for the patients. Anyways, thanks, guys.
Thank you very much, Dr. Chen. I am confirming something in the meantime. However, I would like to mention that with the courtesy of No Scrubs, you will be prized with a set of scrubs worth 350 Rand. And as a specialist, I know you have come across innumerable numbers of scrubs in your life, but I do hope that this one will be extra special as it is from the Wits Student Surgical Society. With that, let me hand over to Sudarshan.
Thank you, Priyanka. Congratulations to Dr. Chen, but also a big congratulations to Dr. Chinara, who was a runner-up. Honestly, it was extremely tight, and I just want to commend all the speakers for what they have delivered tonight. Just a quick thank you to No Scrubs, consistently providing quality scrubs. They know we trust them, we know they deliver, we know their quality, and we know we'll be using them for future events. Their name is kind of self-explanatory. So go buy from No Scrubs. We have come to the end of what has been an amazing night. Despite the copious amounts of knowledge and experience that has been on show tonight, none of it would have been possible without all the different role players. Thank you to Priyanka and all the other SurgStop team members for suturing this event together. To our sponsors and the esteemed surgeons who have ensured the great debate retains its elevated status, thank you. And not least of all, a big thank you to all the attendees for whom without this event would not have been possible. The support we have received has been overwhelming, and we are extremely grateful. Please continue to support the WSS. And maybe this time, let's forget about scalpels and maybe keep a sharp eye out for any of our upcoming exciting events. It has been a pleasure, ladies and gentlemen. Don't forget to smash that like button and subscribe. Good evening.
Bye-bye.
Bye. Thank you.
Thanks, everyone. Cheers.
Bye. Thanks for the opportunity.
Thank you, guys. Well done on a great debate and nice.
Thank you, Dr. Satyabal.
Thanks, Sudarshan, and Priyanka. Thanks so much. Appreciate it.
Thank you, Dr. Chinara.
Zarana, I was you talking. I was
sorry, last thing, guys. I don't know if this is the right platform, but if you guys need anything from plastic surgery, like in terms of, workshops or anything, just give us a shout, and we're always ready to provide assistance. All right.
Wonderful. Thank you for that offer, Dr. Chen. Thank you so very much. We will be in contact with you. I'm sure that's a very attractive offer.
Have a good evening, guys.
You too. Thank you.